Good evening, everyone. Welcome to our webinar tonight. My name is Vicky and I'm going to be hosting this evening. And we're going to be having an expert guest webinar this evening all about chronic limb threatening ischemia. Now, before we get started, I do need to go through a little bit of housekeeping. It's Bryony Webb who is very kindly come to present for us this evening. It's actually, it says 30-minute webinar, but it's probably going to be nearer 45 minutes this evening, but we will make sure we leave time at the end to answer questions. So if you do have any questions, do feel free to pop them into the Q&A box. You'll find that at the bottom of your screen. If you hover, you'll see a little symbol that says Q&A. So do feel free to put questions as you go along in there. We also have the chat box, which I know some of you have already found. So do feel free to join in the conversation in there. Try to avoid putting your questions in there though, because they can get lost sometimes. So questions in the Q&A, other chats in the chat box, and it's great to see so many people joining from far and wide. And if you're obsessed with social media like we are, then do feel free to share that you've joined the webinar today, and hopefully you're enjoying it. So we'd love to see your posts on there. But shortly, I'm going to be handing over to Bryony. She is a lead vascular nurse practitioner at Nottingham University Foundation Trust. And she's going to be talking to you all about peripheral artery disease, chronic limb threatening ischemia, which I struggle to get my tongue around. It's a bit of a tongue teaser, that one. And she's going to talk a little bit about the role of larval therapy and management of arterial ulcers, and talk about the treatment management, long-term outcomes of chronic limb threatening ischemia, and talk a little bit about national pathways related to that and why this all matters to you guys as clinicians. But without further ado, I'm going to stop talking and I'm going to welcome Bryony. Thank you very much for joining us, Bryony.
Not a problem. Thank you very much for having me. It's very exciting.
Oh, it's good.
And thank you to everybody who's joined. I especially thank you to everybody who was originally planning to join us when the date was put out previously. Unfortunately, I had a terrible case of summer flu. So thank you so much for hanging on and coming back when it was reorganised. I really appreciate it. And thank you to BioMonde for having me, because it's
welcome.
Very kind. It's very kind of you to ask me. It's a pleasure to be here. So
first of all,
I'm going to try and work out how to share my screen. Some of you who've been here a little bit earlier may have worked out that I was having tiny technological problems. So actually I'm running off of two screens, but two separate laptops, which is slightly odd. So let's share this. Let's get on the right screen.
Oh, that's me.
Can everybody see the presentation?
Yes.
Fantastic. So if you see me looking at one screen and then looking away, that's because like I said, I'm working off two screens. If you do have any questions, or if I lose anybody at any point, Vicky, if you could keep an eye on the chat, that would be fantastic.
Of course.
Because I am known to waffle. So if I do lose anybody, please let me know. So anyway, so as Vicky said, my name is Bryony Webb. I am the lead vascular nurse, but also trainee vascular ACP at Nottingham University Hospitals. So I'm wearing a couple of hats these days. And like Vicky said, I'm talking about a few things today. First of all, I thought I'd start with a little bit of a chat around what the CMP role is in our hospital, mostly because it's quite interesting. I always find it quite interesting when I speak to other teams to find out the differences between what the team's roles are. I spied some of my team in the attendees list today, so if there's any heckling, I know who I'm coming to tomorrow. So I'm going to talk a bit about the role, and then I'm going to move on to talk about vascular disease. Today we're going to cover peripheral arterial disease, claudication, and chronic limb threatening ischemia. Chronic limb threatening ischemia is one of my passions. I could talk about it forever, really, but I thought it would be useful to start at the beginning and make sure we sort of cover all of the things that run up to CLTI before we jump right to end stage disease. So we're going to talk about PAD and claudication as well. A little bit of a chat about larvae after revascularization. We're big users of larvae, so we're quite keen about it. And then I thought I'd talk a little bit more around wound management in general. There's lots of clinicians here. I can see some of you are from the community. So, you know, your knowledge of wound management will be really good, but I thought I'd just touch on a little bit that's related to vascular, and then some take-home messages as well. So first of all, talking about my team in the CMP role, you can see us all looking very happy in the top corner there. So we, at the moment at NUH, are a team of 9. We've expanded quite rapidly over the last few years, and we support lots of inpatient on-call support, vascular in reach, but we also work majority in the outpatient department as well. So we do lots of nurse-led clinics, wound review clinics, telephone follow-up. The consulting clinics and our emergency clinics are where we see the CLTI patients, so we get a lot of sort of time with CLTI patients in helping them understand their condition. But we do a lot of outreach support, bone sclerotherapy, pre-op assessment, and if there are any other vascular nurses on the call today, they will know that we all have a hand in playing for nurse assessments for the National Abdominal Aortic Screening Programme as well. And then alongside all of the work that we do with inpatients, we do all of that non-clinical interesting stuff that every nurse seems to do now, including things like audits, lots of data collection, incident investigations, complaints, concerns, and service improvement and development. I know that I've seen one of my team that's in that picture, so she's going to obviously tell me off tomorrow, but as you can see, we're all very happy at our job in the top right corner there. So moving away from us and moving on to vascular disease a little bit more, what we've come to talk about tonight. So what is vascular disease? Well, it's a broad term that covers any condition that affects blood vessels, but outside of the heart. If it's to do with blood vessels within the heart, those patients will go to cardiology. But we deal with arterial disease, venous disease, and large vessel aneurysms, but also the consequences of coagulation as well. So DVTs, arterial thrombosis, and embolisms as well. And vascular disease, as some of you may know, can affect really anybody. It's much more common in men over 60 and anyone with a family history or genetic link, and smokers and patients with diabetes have quite significant risk factors as well. In terms of what we see, peripheral arterial disease is probably one of the most common arterial conditions we see. But varicose veins and chronic venous insufficiencies are the more common venous diseases that we see, although I'm not really talking about those tonight. And what we know in vascular is that long-term outcomes for vascular patients are generally quite poor due to the fact that this is often end-stage disease. And patients will often have acute surgical wounds that we might have inflicted on them, or chronic wounds such as ulcers, venous and arterial ulcers that they come in that we have to manage. So when we talk about risk factors for vascular disease, gender is a big risk factor. So men are much more likely to suffer with vascular disease and at an earlier age than women. And it's believed, although it's not very well understood, it is believed that estrogen plays a sort of a protective effect for women, which may be one of the reasons why men suffer earlier. There's also a genetic link. So advanced PAD also disproportionately affects minority populations, and there is this genetic link as well. So if you have a relative, first-degree relative that's had ischemic heart disease or a stroke, for example, then you may be more at risk of vascular disease. And then there's those modifiable risk factors as well. So these are all the ones that the GP and any clinician that you see will talk about to you if you are doing any of these. So if you're a smoker or if you've got hypertension, quite often they want to talk to you. And as clinicians, we're all always repeating ourselves often when we see patients around quitting smoking. But hypertension, hyperlipidemia, hyperglycemia, obesity, and a sedentary lifestyle are all very modifiable risk factors that as vascular clinicians, we spend a lot of time trying to educate our patients. And these are the 6 things that we generally try and focus on. But it's also quite important to know that vascular disease doesn't just come from a chronic sort of process. It can also happen from trauma, so blunt injuries, penetrating injuries like stab wounds, dislocations. We've had some young athletes in recently who've had quite traumatic knee dislocations who have then we've had transected popliteal arteries, so we've had to repair those. So it's interesting because you generally expect that we would see patients over the age of 65 to 70, but we've had a number of younger patients through recently. Generally, the most often that we see for younger patients is those patients who have had traumatic car accidents who then have sort of aortic injuries. But we can see patients who have had fractures, etc., from football that have had vessel injuries as well. So moving away from sort of what we talk about risk factors and the sort of an overview, peripheral arterial disease is really the overarching condition that starts off before patients get CLTI. And interestingly, September is Peripheral Arterial Disease Awareness Month. So what a great time to come and talk to you all about vascular disease and peripheral arterial disease. I mean, I know we're at the end of September now, but it's still a fabulous time to be able to talk to and educate your patients if you're able to. But peripheral arterial disease itself, so we often shorten it to PAD, sometimes we shorten it to PVD, so that's peripheral vascular disease, is an atherosclerotic condition. It results from diminished blood flow to the lower extremities, and we'll talk about how that happens sort of a little bit later on. And we know that peripheral arterial disease affects more than 200 million people worldwide. The development of these atherosclerotic plaques within the walls of the arteries impact on the blood supply. I think that says bloody supplies, apologies, that's a typo. Blood supply to the legs, but it can be experienced in the upper arms as well. And we know that a lot of our patients are asymptomatic. So we often think about peripheral arterial disease as a spectrum, with far left being asymptomatic disease, which is over 80% of our patients, and the far right end there being sort of this chronic limb threatening ischemia, where our patients will present with rest pain and tissue loss. Prevalence is generally about 2.5% between 50 to 59 years, and it does increase with age. So as our patients get older, we see more symptomatic peripheral arterial disease. We expect between 14.5 and some of the evidence says around 18% of patients over 70 years. So as we have an aging population, people are living much longer than they were, sort of 20, 30 years ago. Generally, we are seeing patients that are more extremes of age that are presenting for the first time with peripheral arterial disease. So how does atherosclerosis form? I mean, it's the most important thing that we're talking about here, really, because it's the root cause of all the problem. So atherosclerosis, I've tried to keep this diagram sort of as simple as possible because it's quite a complicated process to understand. But essentially, what we look for and what we understand is that there is a chronic endothelial injury that occurs within the wall of the artery, and that's driven by those risk factors that we talked about earlier. And with that becomes a chronic inflammatory process. So as you can see, there is a plaque in that bottom half of that diagram that's sat within the arterial wall. And that starts by foam cells, so cholesterols being engulfed by macrophages, so big white blood cells. And this is a process that releases inflammatory cytokines. So we end up with a positive feedback loop, which means that continues to happen. And as the lesion begins to grow, and it continues to grow, it has what we call a lipid-rich core. So this is sat within the wall of the artery with a lipid-rich core. And then we have a protective fibrous plaque. So that sort of cap that sits over the top of the plaque is sort of what prevents it from rupturing. And this is a process that takes around about between 20 and 40 years, really. So when we see our patients that are starting to develop symptoms, this has been a process that's been ongoing in their body for a long time. And patients will start to get symptoms when that plaque becomes too big. Essentially, the lumen of the vessel is narrowed so much that blood supply to affected muscles becomes diminished, and then we start to get symptoms. We also experience arterial thrombosis if there was a rupture in the cap of that plaque, and that lipid-rich core can leak out into the vessel, and it can cause blood cells to accumulate, and that's when we start to get an arterial thrombosis. So that's often caused by an unstable plaque. As I said, it's the narrowing of this vessel which limits the oxygen-rich blood supply to the muscle groups, and that's what causes the symptoms that patients experience when they have peripheral arterial disease. But it's also important to remember that atherosclerotic disease is widespread, so it's not just the legs that might be affected, because we often say at work that the pipe and the pumps are all connected. So if you have atherosclerotic disease in one part of the body, you are more likely to have it elsewhere as well. And that means that our patients are at increased risk of ischemic heart disease, they're at risk of stroke and of premature death. So it's quite a big deal. There's been quite a push recently, I think, in the media, and also there's been some push around sort of cholesterol levels in the NHS. So atherosclerosis is becoming more of a problem. And I think it's also becoming sort of more widespread known about it as well, because we are starting to understand that a lot of health problems are caused by atherosclerotic disease. So once we have said, as we've said, the plaque builds up enough within the artery wall and that artery is narrowed, our patients will start to develop something called claudication. So intermittent claudication is sort of characterized with pain on exertion. And as I said, it generally affects the lower limbs, but we do get patients who have upper limb claudication as well. And it's normally pain in the calves, so it's described as cramping or tired legs, but we do get patients who experience pain around their ankles, also within the thighs, in the hips or the buttocks as well, depending on which of the arteries is most affected. Sorry. And I think the most interesting part about claudication is it's pain that's relieved by rest. So it's very transient. It's not there all the time. It can't be improved by sort of analgesias. And these patients find that they can walk a fixed distance before their symptoms start, and then they have to stop. So we will have patients come to clinic and say, oh, I can only walk 100 meters. And if you're in your mid 60s and otherwise generally quite well, or you perceive yourself to be quite well, and you can only actually walk 100 meters before you have to stop and rest every time, if you don't live 100 meters to the closest shop or the bus or to the pub or wherever it is that you want to go, you can start to understand the impact that this has on our patients' lives. And then a lot of our patients will move to using things like mobility scooters because they are unable to walk any further than 50 to 100 meters, and it's such an impact on their life. But treatment for intermittent claudication, on the off when the first time we see them generally in clinic, would be of a conservative nature. So we look at BMT, which is best medical therapy. So we prescribe our patients with an antiplatelet or a statin, although there is some new evidence that actually says low dose DOAC and an aspirin. So low dose rivaroxaban and aspirin is just as effective. And we also talk about risk modification. So one of the biggest things that we do with our patients is to educate them around risk and talk around what the damage of smoking is doing, what the damage of not managing their diabetes or not managing their hypertension is doing, for example. And then exercise. So we will ask our patients to walk for 30 minutes 5 times a week, which when a patient has come into clinic and told you that it hurts when they walk, you can imagine sometimes they're a little bit bemused by being told that the treatment is for them to walk more. But we manage patients with claudication with conservative management, because what we do know is that the invasive treatments for intermittent claudication, such as angioplasties or bypasses, are more risky. So they come with risks associated with limb loss, with distal embolization, with need for further surgery. And if your patients had, for example, a bypass for intermittent claudication, which we consider to be a relatively mild condition, and then they go on and that bypass graft goes down, that patient is then left with the position where they need to have an amputation. So it's very, we counsel our patients in terms of risk, and we try and manage them conservatively as much as we can. 1 to 2% of our patients who we manage will go on to develop CLTI. So according to the GIRF report, which is the Getting It Right First Time, some of you work in various surgical specialties, you may be aware of the programme. They predict that roughly for every 800,000 people you would have in your population, you would have one patient present with CLTI per day. So if it's 1.6 million, you would have 2 CLTI patients per day, so and so on and so forth. And for majority of our patients, at least 70% of our patients, if they manage their condition with conservative management in the ways that we've counselled them in doing so, they actually see an improvement in their symptoms, or they remain the same, and therefore they're able to continue as they are. Managing patient expectation is massive in vascular surgery, particularly for chronic conditions like claudication. We have to counsel our patients about understanding that actually they're never going to get to what they were 10 years ago. We won't have them doing marathons and climbing mountains and things like that again. And actually we have to really do quite a lot of work to help them to understand about what their limits are. So of those 1 to 2% that go on to develop CLTI, let's talk about what CLTI is. So chronic limb threatening ischemia. Some of the nomenclature has changed recently. It used to be called CLI, so critical limb ischemia. It's now generally there's a push to move it to CLTI because it makes it slightly more easy to understand in terms of it being a chronic process. But one of the things I say to people when I talk about this is, you've heard of breast cancer and you've heard of prostate cancer and colorectal cancer. They're sort of the big 3 cancers within the UK. When I talk to clinicians and I say to them, have you heard of chronic limb threatening ischemia? They generally don't know what I'm talking about, because if you don't work in vascular or you don't have experience in vascular, you're probably not sure quite what this is all about. But interestingly, when we talk about peripheral arterial disease, the outcomes are very poor. So symptomatic and asymptomatic peripheral arterial disease has poorer 5-year outcomes than most cancers in the UK, yet you don't hear about it. And then when you look at some of the research that's been done in America, obviously they've got a much bigger population and their demographics are different, but they compared cases of CLTI and 22 types of cancer, and actually CLTI was the second biggest killer out of all of the cancers that they had compared it to. But again, we don't have the airtime perhaps that sort of CLTI needs. Because it's a chronic process, it's not something that can occur quickly, it occurs over the course of a lifetime, and it is related to peripheral arterial disease. And the numbers that we see are certainly increasing, I think, year on year, because we are doing more to try, I think, as in terms of the NHS, they are doing a little bit more to try and get the word out about CLTI so that people can recognise it. Because quite a lot of time we hear that patients with CLTI may have been misdiagnosed as having chilblains or having plantar fasciitis or things like that. And actually, by that point, by the time you see them in the clinic, sometimes it can be too late to reverse the damage that's done. So chronic limb threatening ischemia, so it's defined as rest pain and or tissue loss that's been present for more than 2 weeks on a background of peripheral arterial disease. So that bit's quite important. The patient must have peripheral arterial disease. Although saying that, some of the patients that we see with CLTI, they don't know they have peripheral arterial disease, and seeing them with CLTI is the first time they're told they have peripheral arterial disease. But the important thing is it's the end stage disease process. So if you think about that 40-year process that it's taken for atherosclerotic disease to build up, this is the end stage disease process. So these patients are often quite unwell and quite comorbid. So vascular patients, if you've looked after vascular patients, you may know that they generally tend to be diabetic. They might have renal disease, they may have ischemic heart disease. And so actually, when we manage patients with CLTI, we're also managing patients who have a lot of comorbidities. And it's not just as easy as it would be to manage a disease process in a young person who had lots of reserve. So rest pain is described as intractable pain in the toes, ball of the foot, and in the arch of the foot. And this is quite important. It's a very specific type of pain, and the pain itself is caused by the body's inability to regulate metabolic activity even at rest. So these patients will not be asking their muscles to do anything more or their cells to do anything more than just exist, but actually they will be in pain as a result of it because oxygen transfer cannot occur and the cells are unable to survive. The patients will complain of being unable to sleep, and you often find that they talk about sort of rest pain and they talk about night pain, and actually they have to get out of bed in the middle of the night and have a walk around or hang their leg down, or they become what we call leg hanging dependent. And that's because gravity does a great job in helping blood to get down to these really narrowed vessels down to the toes which is furthest away from the heart, and therefore that's where the symptoms are. But actually, when you go to bed, if you've been sort of sat with your leg hanging down and then you get into bed and you put your leg up, after 2 or 3 hours, the gravitational effect and the pull of gravity is no longer doing anything because you're now lying completely flat. And that's the point when these patients will wake up with severe pain in their feet and they have to get out of bed. And it's quite an important part of CLTI because managing rest pain is probably one of the most important things that we have to do, because vascular pain is ischemic rest pain is very painful, and a lot of our patients will need quite significant amounts of analgesias in order to manage that pain. And when we talk about tissue loss, we mean any tissue loss. So it can be a skin break, it can be a blister, it can be a full-blown arterial ulcer. Anything that breaks the skin's protective barrier that's been there for more than 2 weeks is what we would refer to as tissue loss. And it's not always necrotic toes or large arterial ulcers. Like I said, it can be minor skin splits and small ulcers. And patients don't have to have infection as well. That's one of the quite important things, is that quite often we get referrals where GPs will see a red forefoot with an ulcer on it and assume that it's infected, or clinicians will see it and they will send us to it because the patient has an infection. But actually, if you patient has a cold foot but it's bright red, it's not cellulitis, it's something called hyperemia. So that's reactive hyperemia. Normally when you put the patient's foot down, it goes bright red, and that's to do with the gravitational effect on blood flow, causing that foot to go bright red. So we like to say quite a lot of people that a cold red foot is not cellulitis. But when we talk about CLTI in terms of outcomes, as I said before, vascular disease has poor outcomes generally. And we know that our patients will have, with CLTI, have a 24-25% mortality rate at 2 years. And even with having a major limb amputation within 12 months, which 22% of our patients, so around just over 1 in 5 of our patients will have, it does not reduce the mortality risk. So we will quite often do amputations in these patients as to get them out of pain and to manage their symptoms, but it doesn't actually solve the problem, because what we know, of course, is that our patients have an end stage of a disease process, and quite often they will die within 5 years. So the mortality rate is 50 to 60%, although some of it didn't suggest it's as high as 70%. And our patients will normally die of secondary cardiovascular disease, so they may have heart attacks or strokes. One of the things that's really, really important about CLTI in particular is that early recognition, it saves lives in terms of prolonging them. So if you work in the community, if you work in orthopedics, if you work in renal, or if you work in an area that's not vascular, but you see a lot of patients that are within our demographic, if these patients report having unrelenting pain that disturbs their sleep, you find that they say, oh, I sleep in the chair with my legs down because it helps with the pain, or they sleep with the leg pulled up towards them, so they hold their knee in flexion, or you find they've got a fixed deformity of the knee as a result of sleeping with the knee held up, or they have any sort of tissue loss. I mean, that picture on the right is quite an extreme version. But patients who have got any form of gangrene or ulceration that's generally punched out, can sometimes look like someone's taken a melon baller to a foot, and it tends to be on the malleoli, the digits, or the heel, so bony prominences across the foot, or they have this sunset appearance. So this is this hyperemia that I was talking about. As you can see on the right in that picture there, the forefoot where they've drawn around it, but that forefoot is hyperemic, so that's got that reactive hyperemia. We should be obtaining urgent vascular review at a local or regional centre if these symptoms are present, and we should be looking to review these patients within 48 hours. So the Peripheral Arterial Disease Quality Improvement Framework sets out how soon we should be seeing these patients, and it sets out how soon we should be treating them as well. So if they are an outpatient, we should be reviewing them with inpatient services, so an emergency service, within 48 hours, and we should be looking to treat them within 5 days. So that is the target, and that's what we should be looking to do, because these patients will be in severe pain. And what we know is that recognizing these symptoms early and revascularizing early helps to prolong these patients' lives, and it gets them out of pain. It sorts the symptoms out for them as well, which, as you can imagine, if you've got intractable pain, you want anything doing. And quite often, these are the patients who will ask us if they can just, if we can do an amputation, just because they're in so much pain. And when we talk about treatment options for arterial disease, so we talked about best medical therapy already. So we talked about an antiplatelet and a statin. The antiplatelet helps to prevent arterial thrombosis. The statins have, not only do they have a lipid lowering effect, but they're also known to have a vasculoprotective effect. There's some evidence to suggest that they protect from further vascular disease in the future. And we want to modify all those long-term risk factors. So we're always telling our patients, can they stop smoking? Can they try and manage their diabetes better? Can we get that HbA1c down to a better level? We may consider angiogram plus minus proceed for these patients. So an angiogram, you may have heard of a coronary angiogram. It's a very similar process as they do for heart vessels. We just do it in the lower legs. So using a balloon mounted, a wire mounted on a balloon, a balloon mounted on a wire, and some dye, contrast dye, and some X-rays, we're able to pinpoint where we need to treat within the vessel. And then using an angiogram and the balloon, we open up the balloon with some air. It's not really as high tech as I think that we think it is. And then we would stretch that vessel open, and what we're aiming to do is press that plaque back into the vessel wall so that we're opening the lumen up a little bit so that it's not so narrow. And so when we've done the stretching of the vessel, that's called a plasty. So that's the angioplasty. Angiogram is when we take some pictures and have a look. Angioplasty is when we go ahead and treat. And for those patients who just balloon the vessel is not enough, we would then introduce a bare metal stent to keep that vessel open. And quite often that can just be enough sometimes to get our patients out of pain and have their symptoms controlled. But often that we find with CLTI patients, we need to look for some more open revascularization. So lower limb bypasses, or we may consider amputation, but obviously the more open the surgery, the more the risk increases. So vascular surgery is really just fancy plumbing, if you think about it, because what we're doing is bypassing blocked vessels. Don't tell a vascular surgeon I said that, but that's what we'll call it. It's bypassing blocked vessels, and we can do that at many levels of the leg. We can bypass from the common femoral artery down to low, very distal vessels in the lower leg if needed. And it has good outcomes, but of course it has more risk associated to it. So if a graft was to go down, and that's obviously supplying blood to that foot, we would have a patient back in the same position they were in before. And then after revascularization, we look at things like surgical debridement. So we want to clean up that tissue, those wounds that have got ulcers that have been there a long time, or toe transmet amputations, depending if the digits are necrotic, infected, or gangrenous. And as a last resort, really, we look to do major amputations. So they are life-prolonging or life-saving, and it's not our first-line approach. If you went back to vascular services maybe 10, 15 years ago, in quite a few areas, amputation was a first-line approach. And actually now we've very much moved towards a limb salvage approach rather than going for major amputations. Nottingham has had the highest amputation rate for some time, and we're working quite hard as a unit to try and reduce that, because actually there's no reason why we can't look to do more bypasses if we have that facility to do so. And then obviously, once we've revascularized these patients, whether they've had a bypass because they've had rest pain, but they didn't have any tissue loss, we've now introduced a surgical wound. Or if we've done a bypass because they've had necrotic toes, and we've then gone on to amputate the toes or transmetatarsal, so all 5 toes and the metatarsal heads. Or if these patients have just got quite big ulcers in the lower leg, in the gaiter region, or around the ankle, and we've gone for surgical debridement, we now leave these patients with wounds. And obviously an acute wound becomes a chronic wound after 2 weeks if you look at the National Lower Limb Wound Care Strategy. So we often, as a unit, will use larvae for revascularization. So why would we look at larvae? So in terms of vascular patients, it's a rapid debridement. So we are looking to revascularize our patients first, and we want to debride them second. But what we don't want is the gap between those things to be too long, because actually if you revascularize a wound that has, revascularize a limb that has a chronic wound that has a biofilm or an infection, and we improve the blood flow to that wound, we also improve the circulation of all of the sort of metabolites that we no longer want to be within the system. So we're wanting to revascularize first and debride second. And we know that larvae debrides in an average of 8 days, as per the BioMonde's evidence itself. And we will generally use a couple of bags of larvae to clean up wounds. And we've had really, really good outcomes from that. We also know it's cost effective, it's cheaper than other debridement methods. If you think about not only the physical cost in terms of financial, but actually the cost on the patient. If you have to take a patient back to theatre, it's risk with their other comorbidities as well, and it's painful, and it's not the best way to manage it. So if we can manage with larvae, we will, particularly for our patients who are not suitable to go back to surgery. And we also use an awful lot of VAC, and we find that actually larvae is much more effective than VAC, particularly on these revascularized wounds. And it's non-invasive. So again, going back to those patients who are very comorbid, we know that debridement is safer for them through larvae for a biological debrider rather than it is using a surgical debridement. And if you're interested in why you should use larvae if you don't have much experience in larvae, or why you want to use larvae in vascular patients, or why you want to use it on CLTI patients, there is a really good paper on the BioMonde website. I think it was by Nishijima et al. From 2017 from the National Wound Care Journal, and it talks around the use of larvae on CLTI patients after revascularization. So it's a really good read if you're interested in that, definitely. And now, sort of talked at length about vascular, which is my thing, but I wanted to talk a little bit more around broader wound management in terms of what we see within the vascular department. So this doesn't just cover arterial, this might cover a little bit of venous stuff as well, just before we finish off. So when we think about wound healing, particularly on vascular patients, we look at a lot of factors. So this isn't just specific to vascular, but these are the ones that I've picked out that we think about a lot. So local factors and systemic factors. So we think about the wound size and location, For vascular patients, the underlying blood supply is really important, as I've talked about, revascularization first, and then we would debride second. But also our patients, particularly if they're diabetic, they're very at risk of infection. So they may have acute or chronic infections. We might have some patients who have sort of osteomyelitis and that sort of thing, and we have to do amputations as a result, and we're left with a wound bed that perhaps isn't as clean as we would like it to be. But then also we have our patients with their biofilms as well, so those wounds that have been static and stagnant for a long time, and they have been colonized by a biofilm. Foreign material, if you work in the community, you may have experienced foreign materials within wound beds. We've had patients come in that have had cat hair in their wounds. We've had patients that have had their homegrown larvae, which we sort of try and get rid of quite quickly. People in their own house, when they have their dressings changed, they're not as clean, perhaps. They think they're clean, but perhaps they're not as clean as we would be when we're using sort of sterile fields in clinics, for example. We did have a patient not that long ago who let his dog lick his wound every time he took his dressing off. So you can imagine all sorts of bacteria that was running around in that. So we have to consider that when we look at our patients. But also some of our patients may have radiation damage. So if we do a groin incision, for example, for a bypass or a common femoral endarterectomy to open up the vessel and try and improve the blood flow, some of our patients who perhaps have had ovarian cancers in the past have got radiation damage to the groin. That makes healing in that area really, really difficult. And then systemic factors, particularly for vascular patients. So increasing age, we do see many more older patients, perhaps as people are living longer. And then comorbidities, as we talked about, of renal, stroke, ischemic heart disease. But nutrition, our patients can be overweight or they can be underweight. And actually, the two extremes of weight have their impacts on healing, and both have both make the healing journey could be quite difficult. Gender as well, men are more likely to get vascular disease, therefore they're more likely to have poorer underlying blood supply, therefore we may see more men having more poor healing than women. And of course, this peripheral vascular disease, so we call them vascular paths for having this underlying vascular disease. So what might we see? Lots of different things, really. In terms of venous disease, we see about 80% of our wounds, I think, that we see, particularly in our outpatient clinics, are leg ulcers, and they generally tend to be venous leg ulcers. And arterial disease probably accounts for around about 15% of the ulcers that we see. But we also see patients with mixed disease, so they may have some underlying venous disease as well as having peripheral arterial disease, which means that actually if we wanted to use compression to treat their venous ulcer, that's contraindicated because they've got sort of severe peripheral arterial disease, which makes healing those wounds to be particularly difficult. And those patients who have had arterial disease, who then have pressure ulcers as well, they can be very challenging to try and heal, particularly when they're on the heel, on a bony prominence. We get a lot of patients who end up with calcaneal osteomyelitis from pressure ulcers, so bone infection deep within the heel itself, and that makes it very challenging. And then some of our patients, particularly our younger diabetic patients who come in with diabetic foot ulcers that have peripheral arterial disease, we might do radical debridements on these patients, things like ray amputations, where you sort of take the dressing down 2 to 3 days after surgery and wonder how on earth you're going to dress it because it's such a strange shaped wound. And those are particularly challenging, and we do find that larvae is particularly good for those patients as well. And so we think about all the underlying issues that would be contributing to the delay in healing. And then obviously we think about the pathophysiology of healing and how we can help support that as clinicians. If you work in the community, you might be aware that this year or last year, middle of last year, there was a sequin for lower limb leg wounds or lower limb ulcers. So patients who have a lower limb ulcer that's still present at 28 days are now assessed in the community and automatically referred to vascular services, which is, of course, it's fantastic, isn't it? Because we should be seeing all of those patients who have had leg ulcers. And we have seen in our department a number of patients who have told us that they've had their leg ulcers for 5, 6, 7, 8 years. Now we're able to see them and assess them and get them for some venous treatment, which will mean that actually they have an improvement, which is fantastic, which is exactly what the sequin was set for. It didn't necessarily, I don't know if my team will agree, but it didn't necessarily equate for the 200% increase in venous leg ulcer referrals that we saw within the clinic. But of course, we should be treating those patients if we can, absolutely. But we do know that healing the wounds, particularly not just after CLTI, but generally in vascular patients, is the challenging part. So we know that we have a poor blood supply by nature of the disease and that diabetes further affects arterial quality. But we also know that revascularization is never 100%, and that goes back to that managing expectations of your patients, because we need to make them aware that we're never going to get them back to how they were 10, 15 years ago when they could walk 5 or 6 miles. And we have a high reoccurrence rate of CLTI because it's an end stage process, and vascular, like I said, should be really rebadged as a palliative specialty, because what we're doing is trying to beat the patient, sort of beat the death of the patient, if you like, because it's cell death on a cellular level that we're trying to prevent. So we're trying to get there. We're trying to revascularize them quicker, so that we can get them out of sort of the danger zone and get rid of their symptoms. And there's also a high risk of surgical site infections, particularly for vascular patients, because of their comorbidities. We see lots of complex wounds, so large and radical debridements, as an alternative to amputation, because actually some patients tell us that they don't want to have an amputation, and therefore we need to get rid of diseased tissue. And we do end up having these patients with these weird and wonderful amputations, or weird and wonderful debridement, surgical debridements that can be very difficult to try and promote them to heal. And then those wounds that are in awkward places to dress anyway, so wounds that are in groins, amputation stumps, patients who have got inner thigh incisions from bypasses, and then the deep and hard to dress wounds that have exposed underlying structures as well. We have to consider, are we going to be able to heal this if there is tendon exposed, for example? And we know that we need to try and promote optimal wound environment for healing. And we know that in the vascular department that larvae does help us achieve this by debriding this devitalized tissue and promoting a cleaner wound bed. So just to finish off, not doing too bad. So a couple of takeaway messages that I'm hoping that you've understood what I've said, and I'm hoping that it's been interesting and it's helped you a little bit. But if the few things that you do take away are, always consider peripheral arterial disease. Just have it in the back of your mind. There's such a high proportion of patients that may have asymptomatic peripheral arterial disease that we should always consider that every patient that comes in over the age of 65 probably has an element of peripheral arterial disease. And remember, as I said, that a cold red leg is not cellulitis. Try and remember the definition of CLTI. Does your patient have tissue loss? Do they have rest pain? And try and support your patient to modify their risk factors, particularly in Peripheral Arterial Disease Awareness Month, which is every September. Onward referrals, consider accessing support if your trust or local area has vascular clinical nurse practitioners. I know that my team are fantastic when we get lots of calls asking, well, should we refer, what should we do, what's the best thing to do? So tap into that if you have that local to you, but also tissue viability nurses, both in the community and in the hospitals, are always also really helpful. And if in doubt, refer your patient to vascular services, because the most they're going to turn around and say is, this is an inappropriate referral, but here's some advice. So that might still just get you what you need. And then think about complex wounds, thinking about how you manage them and the underlying vasculature. Use clinical judgment in your dressing choice, and look at your local formularies, and like I said, access your TVNs if you do have dressings or wounds that you're really unsure of how to dress, particularly if they're on vascular patients, because as we said, they can be quite challenging to try and get them to heal. So there's a load of references there, and that's it. So thank you very much for listening. I hope it's been enjoyable and I hope it's made sense. But if you do have any questions, please pop them in the Q&A and we can go through them. But yeah, thank you very much.
Thank you, Bryony. That was brilliant. I have to say, I learnt loads there, and I've definitely decided I need to get up off my chair a bit more and get moving,
Well,
because
if Peripheral
wow,
Arterial Disease Awareness Month has got one person moving, then I will be perfectly happy.
you've got me moving, because wow, thinking that it could take sort of like 20 years
Well,
to
peripheral
start.
arterial disease can start in childhood. People don't realise it
Wow.
really.
Oh,
It's a really long process. I've been reading more about it recently because it's Peripheral Arterial Disease Awareness Month,
yeah.
and it can begin as early as sort of late teens. Yeah.
Wow.
Which is sort of scary to think when I'm 32 and I might have been
Long way off
atherosclerotic for the
my
last sort of 15 years, makes me feel a bit concerned. So it's also made me think that I perhaps need to get off my chair a little bit more.
Well, yeah, as I say, thank you very much, Bryony. That was absolutely fantastic. And we've got some thanks coming through onto the chat now as well, which is great. I have got a few questions that have come through, so I'll read them out and we can see if we can get them answered for you. But before I do ask that, I've had a couple of people asking if there's going to be a recording available of this. Yes, there will. It's going to be on our YouTube channel and on our website probably next week now. Considering it's the end of the week. Yeah, do look out for that coming to various platforms. If you've got any questions that you think of after the day, you can email myself at clinicalsupport@biomonde.com. And if you want that paper that Bryony spoke about, email that one and we'll get that through to you as well. But let's see what questions we've got now. So first one is from Louise, and she's put, does an ABPI above 1.3 or incompressible suggest and or confirm after, I can never say that word,
Atherosclerosis.
thank you, in an
So,
asymptomatic patient?
So yes and no, really. So anything above 1.3 is a little bit sort of unreliable. Patients who have got diabetes, those patients with a high HbA1cs generally tend to have quite calcified vessels, which makes them incompressible anyway. So actually what you get above 1.3 is a bit of a misnomer result where you can't tell if it's atherosclerotic disease that's causing it or if it's calcification, which may have a slightly different sort of underlying process. If you get an ABPI of 1.3 or above and you're not sure what to do, I think you should refer your patient to vascular services because they will be able to tell you what the best option would be. And quite often, if we have an ABPI of more than 1.3, we will go ahead and do an arterial duplex because actually some imaging tells you what you're looking for. And it's generally more objective than an ABPI, which can be sort of vary in terms of results.
Okay, thank you. And sort of a follow-on question from that, should we then recommend screening, i.e. lipids/cholesterol levels?
So it depends on the age of your patient. So when people go for their MOT, which I think they get at 65, it's either 60 or 65, they start to get a yearly MOT. Quite often they will have lipids tested, LFTs tested yearly. I don't think they do enough in this country necessarily to promote lipid screening. And I think there should be more widespread use of statins, particularly in patients who have peripheral arterial disease. But then I suppose the argument in return to that is, how do you find everybody? Do you send everybody in the UK for a screening test, and who's going to pay for that? And what are you going to do with all of those misnomers that you find on bloods that aren't related to lipids tests? So I do think that there probably should be more done for lipid screening. And I know that when we see patients in clinic, particularly if they're new to the service, we will quite often send them for lipids so that we have a baseline result, and the GP will test continually, particularly if we've started them on statins, they then have their bloods tested again 3 months later.
Okay, next question regarding wrist pain. What analgesia type would be best? Or like for maybe nerve pain, would you say NSAIDs, or is there something else?
So for true ischemic rest pain, our patients go on opioids generally. We use Zomorph and we use Oromorph and we use Longtec and Shortec, so oxycodone as well. And it's quite a difficult balance because we obviously have to make sure that we're not, particularly if they've got renal disease, that we're not knocking their kidneys off, that we're not over-opiating them as well, because they generally tend to be in the sort of 70s and 80s. So for rest pain, we would go direct to the top of the tree, really. For neuralgic pain, so for nerve pain, generally we use amitriptyline or gabapentin or pregabalin. But we obviously, with gabapentin and pregabalin, you have to titrate those doses as you start them. And you have to do a lot of counselling with your patient around telling them not to just stop taking them as well because of the risk associated. Non-steroidals can be useful in some occasions, but generally we wouldn't use non-steroidals because they're just not strong enough for the pain that our patients are experiencing.
Sure, sure. And I guess with everything, it's unique to each patient.
It is, and
As it
it
is.
takes a lot of. One of the things that I'm quite interested in is pain control for vascular patients.
Yeah,
Within vascular surgery, we have a subsection of patients who have a history of IV drug use or are current IV drug users, and managing pain in that subset of patients can be very challenging because of the issues with substance misuse, but also
yeah,
them being resistant, opioid resistant, and that sort of thing as
probably.
well. So it can be very difficult to get on top of patients' pain.
Yeah. So, thank you for that, Bryony. Next
Right.
question. Do you see a lot of, do you get involved a lot in diabetic foot ulcers, and can you sort of comment on that, about anything like to do with?
So
Yeah.
I do see quite a lot of diabetic foot ulcers. So we are in the middle of COVID, we took on the diabetic foot service for Nottingham, and we do that jointly with some of our diabetes colleagues across site, because we've got 2 hospitals in Nottingham and we work across site.
Yeah.
So if stable diabetic foot ulcers would go to their service, but urgent and acute diabetic foot ulcers would come to our service. So um, in terms of what we see them for, often we see them to manage their infective process or the sepsis associated, and to revascularize them. So we're looking to see if they have an underlying peripheral arterial disease or stenotic disease within the artery that would need to be treated,
Yeah.
before we would then really sort of debride whatever is the, wherever the ulcer is, and then they are then generally managed by the community services or the diabetic foot services beyond that. So we, in terms of what we do for diabetic patients, anything that involves sort of rehabbing or offloading or air cast boots, all those sorts of things, is done by the diabetic foot service. We manage them in the very acute stage more than anything.
Well, thank you very much. Charlotte has asked if she'll be able to access a copy of the slides. So would you be able to share a PDF or anything like that?
Um, I don't know. I've never been asked that before. I mean, if I can work out how to put it into a PDF, then I might be able to. Yeah,
I'll
I'd
tell
have to
you
work
what, Charlotte,
that one out.
Charlotte, if you drop us an email, clinicalsupport@biomonde.com, I can show Bryony how to turn it into PDF, and if she's happy, we can then pass it on
I
to.
mean, in terms of technology, I'm working off 2 separate laptops here, so you understand that I'm not very technologically minded.
We can help with that. But yeah, anyone who would like the slides, as long as Bryony's happy to share them,
Yeah, that's
drop
fine.
us an email, clinicalsupport@biomonde.com, and we'll get
Fabulous.
that sorted. Um, that looks like it's the last of the questions for you, Bryony. Although,
I think I've found one for you in the chat.
oh,
So it
okay.
says, I mean, it might be for both of us. It says vascular wounds can be quite dry by nature. This is a question from Kim Prince. It says,
Oh,
does
that's
this
lovely.
impact the efficacy of the larvae? From my point of view, I don't know what you would say, Vicky. We would soften dry necrosis before and try and lift anything off that was very dry, by using something like a hydrogel, or we generally would use flamanol, although we would remove the flamanol, clean the flamanol off before we would then put the larvae on. So what we're looking to do is try and soften up that wound bed, and sort of add some moisture to it before we then sort of put the larvae on and let them do their job.
Yeah, so basically that really, I mean, so the thing with it, I call it like knock-on wood necrosis. Everyone knows what I
Yeah,
mean.
it's that really dry escar that you can
Yeah,
tap and hear at the other end of the ward.
exactly. The larvae, they will try their hardest to break that down, but the problem is the enzymes just cannot liquefy it quickly enough for the larvae to get it on board, and they perish. So it doesn't even need to be that soft. It can be sort of a leathery sort of consistency. I love the words we use in wound care. But so, whatever you would normally use to rehydrate a wound on your formulary, that's absolutely fine. And as Bryony said, obviously just making sure you're really cleaning off anything like a gel or honey, whatever you're using, to make sure it doesn't affect the larvae when you put them on. But yeah, it doesn't have to be super, super soft, but not knock on wood. Cool.
I'm going to start using the term knock on wood.
I've used it for eons. I think it just really, everyone understands what you mean by that. Oh, someone, I can see a question from Rosie. What was your path into vascular, and have you got any tips?
So I have been in vascular for nearly 11 years now. So I qualified in January 2014 as a nurse. And in my second year of training, I had a placement on the vascular ward. And prior to that placement, everything that I had done in my training hadn't felt very inspired by it. I mean, if I'm very, very honest, I was never somebody who went into nursing to sort of care for people and look after people. I was not one of those driven by a vocation type of people, which some people are, and that's great. And I wasn't one of those people, and I was not inspired by anything that I had seen in a placement before that. And then I had 8 weeks on the vascular unit at QMC in Nottingham, because I did my training at the University of Nottingham, and I absolutely found something in vascular that inspired me to just stick with it, and I really, really wanted to go back into it. And I think what it was the concept of amputating a leg to improve someone's life sat really bizarrely with me for a little while, because I thought, oh, this is really weird. But actually, when we had these patients come in who were really sick and they've been in pain for a really long time and that they just couldn't cope, and these poor people are begging you to cut their leg off, it was a sort of strange place, sort of one of those things you think, how did I get here in my life? But and actually those patients went to theatre, and when we were effective at managing their post-operative pain, actually they were so much better, they were so improved. I wouldn't say they were, they're not happy, but they seemed to have a bit of a spark back, and they were more comfortable. And what we'd done by doing something as drastic as chopping their leg off is actually improved their symptoms so much that they can get back to some semblance of a normal life. And I think that was the bit that inspired me to go into vascular. So after that was a placement in my second year, and then I worked for NHSP. I did a lot of healthcare assistant work on the vascular unit. And then when I qualified, I applied for a job on the vascular unit. I've been there ever since. So I did 5 years as a registered nurse. I've done 3 years as a vascular nurse practitioner, and I've done 2 years now, 2 and a bit years, as lead vascular nurse for Nottinghamshire. And then in January of this year, currently, I also started my advanced clinical practitioner training for vascular surgery. So I'm wearing a couple of hats at the moment, but I must be nuts to do both of them at the same time. But I have never, I don't think I could work anywhere else. I don't think that anything else inspires me. Every day on the vascular unit is different. I love the patients. They're not, they're not everyone's cup of tea, and I understand that. But I'm inspired by the people that we look after every day when I go to work. And when I was younger, I never really, when I look back and think about what I could have done instead, I don't think I would have the job satisfaction that I have from anything else that I have from my job now.
And I can totally tell that you're really into what you do and
Oh,
really
I'm
being
obsessed. I could talk
you
about
speak
vascular
really well about
all the time. Honestly, I talk everyone's ear off. I'm like, have you heard about this? Can I tell you about this? Can I talk to you about aneurysms?
So that's the tip, is just get really obsessed with
Really obsessed. Read everything you can
it.
read. Just be obsessed with the area that you work in, because
Oh, fantastic.
people talk about nursing and allied health positions and physiotherapy and all that sort of thing being a vocation. Like I said, I was never somebody who was inspired in a vocational sort of way, but I wouldn't do anything else. I think it's the best job in the world.
Fantastic. Well, thank you very much, Bryony. It's been a really great evening, and the thanks in the chat box are reflecting that as well. So thank you ever so much for joining us this
No
evening.
problem. Thank you so much for having me, and thank you for everybody who has listened to me go on for the last hour. And I hope it all took something useful away from it. And I did put my email address, I think, is at the end of. Oh, I will do. I'll put my email address in the chat. If you have any other questions, you can email me.
Great.
Make sure
Thank
it's
you,
going to the right
Bryony.
place, everyone. There we are. That's my email address. And if you think that you want to ask me something that you hadn't thought of right now, you can email me and I'll have a look when I'm back at work.
Fab, thank you very much. Well, just a couple of few closing slides before you all escape. Do look out into your email inboxes, because you will get an email just confirming that you were here, and you will get a certificate. So for those of you who are revalidating soon, myself included, you will get that certificate to add to your collection. If you enjoyed this webinar, we have just recently planned the rest of our autumn term. So we have got some really interesting webinars coming up over the next couple of months. You can head over to the website and you can see all the dates, and you can sign up for the ones that you like. And if you want to learn a little bit more about larvae, because obviously you've heard how they can work really well with the PAD patients, we've got other ways that you can learn more about larvae. So we've got our videos under BioMonde now. We've got our module-based training, which is known as BioMonde Academy, and you can do a session with me booked online through BioMonde Direct. So go head over to the website and you will find all of that there and more. And if you get any questions after today that aren't necessarily aimed at Bryony, as I said, we've got our email address, clinicalsupport@biomonde.com, or you can telephone us 7 days a week. Myself or my colleague Rebecca hold the line. So there is always someone you can get hold of. And as I said right back at the beginning, do please share on socials that you've spent time with us this evening, and I hope that you have really enjoyed it. I know I have. So on that note, thank you very much, everyone, for being here. I hope you enjoy the rest of your evening, and maybe we'll see you on another webinar soon. Have a good evening.
Have a great evening, everybody.
Take care.
Bye.